Welcome back, warriors and supporters, to another great episode of CWF Presents CRPS/RSD is Real. This is episode 17, and today we are joined by Dr. Chauncey Jones of Lone Star Infusions in Houston, Texas. Lone Star Infusions was born in 2015 and was the first ketamine clinic in Houston, Texas. They offer individualized plans for each patient's individual needs. Today we're going to take an in-depth look at the different services that are available and get to know Dr. Jones. So thank you so much for joining us today, Dr. Jones.
Would you mind sharing with us how you came to know of CRPS and what caused you to want to learn more about it and to treat it?
Certainly. I grew up in a very underserved rural part of Louisiana. Most of my background was education and agriculture. I actually did animal science pre-vet in college, seriously considering doing large animal medicine, and had a change of gears midway or toward the end of college and decided to go to medical school. And so I did research in both areas. I shadowed both types of physicians. And once I made the decision, I was fully committed in that direction. However, that initial direction was to do rural family medicine because I was from a rural area and I was thinking about rural veterinary medicine. So I said, well, man, I may as well do rural family medicine. And midway through med school, I did an anesthesia rotation, considering if I was going to be in a very rural area and perhaps the only doctor for miles around, I needed to be capable to handle whatever came through the door. So I did an anesthesiology rotation and found that I was very well suited for that environment to get people to relax very quickly, to establish some rapport, to help patients calm down, but also think very quickly on my feet and have good hands for procedures. So I had a mid-med school crisis and switched to anesthesiology. But my exposure to CRPS, which is a pain-related diagnosis, which maybe is part of the path that ultimately led me to anesthesiology. Actually, I call it my first lesson in medical school. And so I was flying from Louisiana to California to start medical school at Stanford. And there was a young lady on the plane sitting beside me. And a small conversation started. She learned I was going into medical school, and she's like, cool. Have you heard of RSD, or the new name is CRPS? I haven't. And I said, no, ma'am, I don't, but I'm all ears. And so I got my first lesson for medical school from a patient on the way to medical school who had CRPS. And she asked me to do my best to try to find some additional treatments and cures. And that was over 20 years ago. So that was my first exposure to CRPS. I had dealt with pain treatment in animals before, people's pets, dogs and cats, but mostly in horses, mostly rodeo horses or race horses or pleasure trail horses.
Wow, that's a very unique story to learn from a patient on the way to medical school. I like that a lot. It seems sometimes our patients helping patients at times is the best for at least the tips and the tricks.
Mm-hmm. Absolutely. I remember having a professor who I was picking her brain on clinical research, and she said she spun her wheel and didn't make much progress for many years until she was at a community gathering in Oakland, California, and she was explaining the research that she wanted to present for this community. And this little lady in the front row stood up and said, you know what your problem is, baby? You come in here and telling us what we need instead of asking us what we need. That has also stuck with me to try to meet patients where they are and see what their needs are, and then take the scientific and evidence-based knowledge that we have to try to apply it to that request.
That's, I think, difficult at times because when patients have tried so many things, whether they're open to trying something new or willing to take a risk or just try something different is difficult at times, or being willing to trust a physician. So if you're met with that, how do you handle that?
I try to establish some rapport, so find some commonality that we can discuss. But the bottom line is just as part of that process, figuring out where that patient is physically, mentally, emotionally, life, family, job, and from there, see what they're open to and let them guide that path. From the clinical standpoint, Some of it comes down to, is it a focal area where one particular nerve is involved, which gives me some tools that can actually focus on one nerve, or is it something more total body where we need to look at something more of a systemic treatment? Some of those things we discuss. A lot of the challenges is perhaps, for lack of a better explanation, undoing previous experiences. If a patient comes in with something new and I'm lucky enough to be the first physician they speak to, then kind of it's an open book. But I've had several patients who have told me that, oh, I've tried that before and it didn't work. And some nuances that you have to get down to really determine whether or not it truly didn't work, or if it was not done in the correct way, or if it just wasn't the right modality for that particular patient. One example that comes to mind is I was working in one of our facilities covering the anesthesia services, and one of the ladies who worked in that facility, young, healthy, looked like she went to the gym regularly, was walking around with crutches. I just met her, so I wasn't going to probe too much, but after a month of her being on crutches, I asked her how things were going, and she mentioned an injury that was not healing and physical therapy wasn't working, and she was resigning that she might be on crutches the rest of her life, and she was in her 20s. After visiting with her for about 5 minutes, I realized that she was having a neuropathy that was hyper, meet all the criteria for CRPS, but very similar treatment profile for a particular nerve in her leg. And insurance was a challenge for her. And so I talked to her about peripheral nerve stimulator, and she said, you can't do that. And I said, okay, do you have a TENS unit? And she said, yes, they've been having me put it on this muscle the whole time. I was like, it shouldn't be over the muscle, it should be over the nerve. And I showed her I drew a line, I showed her exactly where to replace the TENS unit to stimulate that nerve. And 2 weeks later, she had no more crutches and went back to the gym. So it was a pretty amazing story. And so she could have very easily told me, I'm not going to try a TENS unit because I've tried it before, which was true, but just a slight movement, literally of about 3 inches of where she applied it, made all the difference. But in that scenario, it wasn't a patient per se, but it was someone that I didn't just walk up to the very first day and say, hey, let me tell you what to do. And I had to establish some rapport and get to know her. And that's what it takes, the trust factor.
Thank you for sharing that. I really like that example a lot of building that trust and that relationship and offering suggestions and not demands so much. And I like that a lot of seeing what they're open to, what they've tried. And I think that it's very important that you brought up undoing what could have been done not correctly the first time. And I think that as I've talked to more people, I've learned certain methods that certain treatments are done. And I can't help but think in my head how many people are walking around thinking, say, a nerve block doesn't work for them because it just wasn't put in the right spot. Or ketamine, it just wasn't the right dose or the right time frame. And it's hard to know that certain options have been closed to people in their minds because it wasn't delivered to them correctly. So I really like that you brought that up and that you try to work past that and work with people and help them work through that.
Yes, ma'am. The other side of that same coin is setting realistic and honest expectations. If I'm visiting with a patient, I will tell them there's a high likelihood or moderate likelihood that this may or may not work. If it does work, then this is what you would expect. If I'm going to consider it not a successful therapy, then this is what you should expect. And if we get to that point, then next steps would look like this or that. And so they go home having some idea of a larger plan rather than, let me poke you right here and tell me if it worked or not. Early on in my career, I can sometimes be a little long-winded, or why use 3 words when 30 will suffice? But in me trying to be short-winded with some patients and not disrespect their time by running over, I found that I needed that extra detail for some patients because, for example, one patient came back to visit and they said, oh, that shot didn't work. And despite me telling them that they had probably 2 things going on, I had to ask them, okay, well, tell me where the pain is at this point. And they said in an area that we did not address. I said, what about the area we did address? Oh, that pain's gone. I was like, great. we have addressed one part of it. Now let's move on to the next. And so it just takes a little bit of extra communication, effective communication, closed loop communication, and meeting people where they are. I mean, with walking around with a normal aptitude to speak English in the United States takes 12 to 1500 English words. Spanish is about the same, French is a little more, but to be able to walk around as a physician and speak to other physicians in medical language, it takes 5,000 words, but that doesn't mean we need to use all 5,000 with our patients. And in fact, sometimes I have to figure out what level of communication and understanding they have, and then start there, and then we pick up from that point.
And I like that you make sure that they have that big picture, all the details, so we know what we're doing, why we're doing, what to expect, what we can do next. And that part right there is really important, because I feel a lot of times we get to the point of not having hope when we try different things. We might not fully understand what they're supposed to do. We just want some relief. So having that and having the hope that there's something else we can try if this doesn't take this time. And I was curious if we could talk about the different types of treatments that you would do and how you would evaluate what each client would need.
I'll, true to what we just discussed, I'll start on the big picture, then drill down more specifically. But first, I encounter CRPS from several different avenues. One is receiving them for the first time when things are very early on, which is an honor and a privilege to be able to be in that position. Sometimes they've had things happen from various different people over the course of some extended period of time. And then there takes a little bit more trust building, because it's not just me that they have to trust the system and American medicine, period. But the other exposure I get on some occasion is expert witness review work for pain procedures and seeing patients that have CRPS. And I see the long-term frustrations come out in a very different way. Oftentimes, one of the most common reasons for suits is that a patient feels abandoned. And so a lot of times I'll look at the chart and it's like, oh, they didn't try this or didn't try that, or I wonder how that I wish I would have been a fly on the wall to see how the communication went with this, because it's unfortunate that it has gotten to this point. So that's certainly very motivating to spend that extra time talking to patients and make sure that they feel heard, but also make sure that I feel understood by the patient. And so drilling down a little bit, oftentimes I will approach patients that come in with pain that's neuropathic, meaning nerve related in nature, often radiating, which we call radicular. Then I'll start with an open mind with that and not jump down the CRPS pathway, because CRPS has a certain specific set of diagnostic criteria, but it's a continuum to some degree with other types of neuropathic pain, and the treatments for all of them are quite similar. So I look at it from that standpoint, so that I make sure I'm not putting blinders on too early in the process, to make sure we're hopefully evaluating thoroughly before we focus in on any one thing. Our pain clinic, which there's several of us that work together collectively, but our pain clinic will often see the patients. The first line of therapy is physical therapy, and then whatever it takes to get them through physical therapy, which honestly is very similar to what I do in the perioperative setting when we're doing a total knee replacement or a total hip replacement. We want to get them through that process, let them know what to expect, and then get them the physical therapy and do whatever it takes for them to engage in physical therapy, whether that be a nerve block or just setting expectations, etc. Because if you send a person to physical therapy and they're not mentally and physically ready for it, then it has a less of a likelihood for success. So a lot of it is preparation and education. We can also do topical creams or lidocaine patches. There's, depending on the location, if it's a limited area, then there are certain blocks that can block primary nerves or the sympathetic nervous system to see if there's a response for that. There are peripheral nerve stimulators that we place, one of which is a treatment peripheral nerve stimulator, but it actually is for a limited time period. So instead of implanting something and implanting a battery that's there potentially indefinitely, the first line that I like to go to, if it's a peripheral nerve that's the issue, or peripheral nerve distribution is to place a nerve stimulator wire that's about the size of a hair, but the battery just sticks on a sticky pad on your leg or on your arm, and it stays in for 8 weeks. And 80% of patients that are well selected will respond very nicely to that. And then when we take the wire out, there are no more devices that they have to go home with or live with, and about 80% of patients continue to have benefit from that. So that's a good modality to consider for certain situations. If there's a broader distribution of pain, then cryoneurolysis or freezing peripheral nerves is another technique that I'll do. And we talked earlier in our conversations, we talked about an ounce of prevention. The best way to treat CRPS is to not ever get it. We just don't always have a crystal ball. But for high risk patients and for a lot of the patients that I see coming in or planning to come in for surgery, I'll get referrals to actually freeze the nerves going to the knee before the knee replacement ever occurs to minimize the risk of things happening. It's certainly a very broad and diverse option. We'll ultimately also consider, if need be, central nerve stimulators or spinal cord stimulators or dorsal root ganglion stimulators to help with certain situations as well. One of the things that is certainly not unique to our practice, but we have the oldest ketamine infusion clinic in the greater Houston area. And we treat two large patients with that. Those with mental health diagnoses such as depression, particularly depression that has been resistant to other treatments, including medications and electroconvulsive therapies, and respond to ketamine infusions, as can post-traumatic stress disorder or PTSD, chronic anxiety, and many other things in that category. On the other side, we also treat neuropathic chronic pain with ketamine infusions as well, particularly if it involves multiple parts of the body or has similarly been resistant to more conservative therapies and physical therapy. So that would include CRPS, but it also includes other types of chronic radicular or neuropathic pains. It's interesting that ketamine treats both of those larger categories, because when I approach a patient, I'm approaching them from those two categories. Whether it's just before surgery, you're going to have a person who either is in pain or is expecting pain very soon, and you're going to have a person who's very anxious or nervous. And so I also approach the CRPS patients or chronic pain patients in that same category. Okay, let's try to figure out physiologically what's going on and what's causing the pain, but also how are you doing up here? How are you handling it? How can we help you handle it better? Whether that's therapy sessions or ketamine infusion sessions or some combination of that, or is this maybe just me sitting and having a heart-to-heart with them? Ketamine does help to repair some of the neural pathways, whether it be for chronic pain or connecting the logical and the emotional centers of the brain to help there be better connectivity there. But if you've never, I'm from rural Louisiana, so if you've never run a chainsaw or driven a tractor, I can't give you the keys and say go after without teaching you. And so just because we help a patient to have better connectivity there, then they also need to be able to know how to have and use tools to address that. So with better connectivity, you can realize that either myself or listening to a therapist or psychiatrist can teach you distracting maneuvers or teach you things that cause less stress teach you ways to address things that are causing less stress in your life in a more proactive manner. And ultimately, that helps break that cycle between pain and depression, or at least improve it.
And I feel warriors are constantly going through that cycle of grief, right? We're constantly mourning ourselves, but every time we lose an ability, now we have to start over because now we're going to mourn that. And I think for me, it's hard to get a handle on it, and then something else is taken. So then now I have to start over. And you never know when a CRPS patient walks in your door, what stage are they at, or what stage are they at today? And being able to address both of those at the same time is really huge. And you answered my question, because I was going to ask if you were treating someone for CRPS pain, if it would help the depression, anxiety, and PTSD, because a lot of people that have this have all of those. So it's very important to, like you said as well, teach them how to have that new mindset, view, or relationship with pain after hitting that soft reset. And
Yes, ma'am.
yes, treating the whole individual, because this is definitely a whole body and mind diagnosis.
Yeah, probably in spirit as well, right?
Yeah.
Mind, body, and spirit. Yeah. I just actually came from taking care of some patients recently, earlier today. And I noticed that if it was a new patient and I sat down and said, "How you doing?" They looked at me and I had to really explain that I really wanted to know how they were doing. Whereas the patients that have seen me several times, I sit down and say, "How you doing?" We'll go right into telling me exactly how they're doing, which is great. So that's one of my kind of tests for that trust factor that we talked about earlier.
Yes. And I have noticed as well too, the difference between patients is the difference between a newly diagnosed and somebody that's had this for a very long time. The level of hope is very different.
Mm-hmm.
And even the difference between men and women is substantially different as well, of how men grieve themselves and how women do. And I think for men, it seems to be a little bit harder. And I think that's because they're there to be the protector, and they feel that that's been taken from them. And I can't imagine what that would feel like, because I don't have anything to associate that to. So for
Mm-hmm.
women to understand that concept, I think is a little bit more difficult. But it's just really individualized of each person, of what their makeup is, what their history is, and what they're doing to handle it, and making sure that they're equipped on all aspects of that. And that's comforting to know that you do that.
Absolutely. And the other factors that come into it is gender, certainly a very large part of it. Culturally, some people are more conditioned to accept and speak of pain or challenges, and others are taught to hold it in, which can, both of those can be very challenging, as well as the personality type. The typical type A personality wants control, and if anything hinders that control, there's a war on their hands. So I'm sure a lot of your warriors out there are trying to balance that combination, which is challenging.
Yes, it seems a lot of people that I've met with this illness, though, they're fighters. They want to fight for
Mm-hmm.
something better. They don't give up. So
Mm-hmm.
they're definitely strong. We're all very strong to carry it in general, just because it's out there when it comes to the level of pain. I didn't understand really until it had jumped to my foot, because I had it in my hand for years and didn't know. And the pain there is so different than the pain when it went to my foot.
Mm-hmm.
And it's difficult, I think, to constantly have to remind people, but they're not going to register something that's not supposed to cause pain as painful.
Mm-hmm.
And having anybody that understands that, or having a physician look at you and say, no, this is real.
Mm-hmm.
What you're experiencing is real. And I think that alone is the start to that relationship that you build with your patients.
Mm-hmm. Absolutely. We can mentally try to identify, but until you have some life experiences, it's much harder. You have to have a very vivid imagination, such as anxiety and panic. It's not something that had been a big issue for me, but I remember after taking one of our big physician examinations, I started going through my answers and everything, and I actually had chest pain, and it's like, oh, okay, so this is real. I feel it now. I can identify with my patients in the future. So, you know.
So I was curious to see, I read on your website about how you are involved in ongoing research and education, and also teaching other colleagues your techniques, and facilitating learning opportunities, advancing the field of ketamine therapy. And I was just wondering if you could maybe elaborate a little bit on that for us.
Sure. So the two things that I like to think about is the big picture, making sure we're not going down a rabbit hole, but then as you look at the big picture, you've got to turn the page or go from one chapter to the next. So as you go to those chapters, make sure you actually read the footnotes and read each word on the page, as opposed to just looking at the title of the chapter and moving on, because that's where those slight nuances on where to put the stimulator make a huge difference. And For our group of anesthesiologists, we're fairly spread out across multiple sites across town. And so each year I'll have a conference where we all get together and we'll discuss lessons learned. We'll discuss our newer techniques that we use for ultrasound guided procedures, nerve blocks, etc. We have found that, for example, lower doses of some of the local anesthetics allow us to get these patients and walking, but not affect the pain that we're helping or not affect our pain treatment. So that's important. At some of our organizations, our societies, anesthesia societies, I'll also teach some of the cryoablation techniques, not sponsored by the companies or anything like that, just on my own because I feel like it's important. With the ketamine, you can have anybody walk in and put an IV in a person to do a ketamine infusion, but I would say as much as half of the outcome has to do with that first 10 or 15 minutes of sitting down, talking, listening, and setting expectations. And so that interaction is key, just like the interaction before a patient going to sleep before surgery can either make them wake up more relaxed or more anxious before they even realize that they're waking up. And I've had some very good stories with patients first waking up when I have them pick out their favorite dream or vacation spot before they go off to sleep. The other things are trying to drill down with ketamine and use less of a shotgun approach as far as the diagnosis. So what diagnoses are actually responding, which ones are not, what's the appropriate dose, what's the minimal dose that we can get away with and still have good effects. So those studies are all ongoing. One thing that is not very well borne out is what's a good time frame. Ketamine is not an infusion where we can, or a drug where we can give you one dose and expect a person never need to come back. But we want to get that as infrequently as possible. So, what is that correct treatment dose to determine whether or not this patient is truly getting benefit? So those are some of the things we're looking at to try to get a better feel. And each diagnosis seems to carry something different. For pain, now you heard me stress that we treat chronic neuropathic pain. Certainly nerve pain is the pain that responds better than other types of pain. So we really focus on that. We felt like the benefit of trying to treat other pains with this was not appropriate as we got more and more information and data. With the anxiety, depression diagnosis, then it seems that the dosage amount and the treatment frequency is slightly different as well. Teasing those two things apart, and then when you have, as you mentioned, a patient has both some anxiety, depression, and pain, and they may actually be interrelated, one is causing the other or vice versa, then trying to figure out the correct dosing timing to get that done appropriately, especially since there are other factors in the background. Insurance companies do not currently acknowledge ketamine as a therapy for these, and so insurance companies do not cover ketamine for this purpose. And so we want to be as respectful of people's time and money as we can. And the more data that we do get out there and get published, then it's going to hopefully push the bar more towards having insurance companies ultimately have to acknowledge that. There's also legislation that was passed that will take effect in 2025 called the No Pain Act. And so the No Pain Act dictates, at least for Medicare patients, that if there's any FDA approved non-opioid modality, that Medicare has to cover that idea or that device. So we'll still have to see if they actually honor the ketamine for that. But certainly many of the other things that we have not been able to do, such as some of these stimulators, et cetera, for patients because insurance did not approve, we have one more feather in our cap to push against that for FDA approved items. So that's a bigger viewpoint and drilling down a little bit into some of the questions and movement forward and trying to figure out what combination of things and what frequency and dosing interval makes the most sense for patients. Knowing also that there are many more drugs in the pipeline now that can also be additional non-opioid adjuncts. So the point is not to find 100 things and give every patient 100 different things. The challenge is to know that there are 100 things out there, listen to the patient and see where they are and figure out the combination that may work best for that particular patient. And so I have patients come to the ketamine clinic, and as we talk, they may decide that they would also need or would prefer to have a peripheral nerve stimulator or the cryoneurolysis to the nerves, or stellate ganglion block or lumbar sympathetic block, which are those specific blocks are ones that block the sympathetic nervous system, try to help upper extremity or lower extremity CRPS. Stellate ganglion block has also been shown to also help with PTSD. So that could be a 2-for-1 special for a person whose pain is turned into more of kind of an anxiety, traumatic experience.
I have a question with I always say it wrong, cryo freezing. Yes. Is that, sorry.
That's okay.
I was wrong.
The fancy word is cryoneurolysis, but hey, I'm hearing you, and you said freezing of some nerves, so I know exactly what you're talking about.
I was curious if that, how that would work with the patient that has that hypersensitivity to colds.
Mm-hmm. One of the contraindications, I'll just start there with cryoneurolysis, is patients who do have a true cold-related diagnosis. There are various blood disorders that when a patient gets cold, their red blood cells may burst or may get super thick blood, or etc. So certainly we don't want to subject those patients to it. Those patients then I would consider nerve block or the typical radio frequency ablation where we actually burn the nerve as opposed to freezing. But yes, one of the nuances where we talk about being upfront with the patient to determine likelihood of benefit, expectations, and next steps is how hypersensitive they are and whether or not I think the cryoneurolysis is the correct therapy versus topical versus the stimulator. So if I have a patient who is on the hypersensitive side but doesn't have CRPS diagnosis, then most of them do very well with the cryoneurolysis. If I have a patient that truly is, you can barely touch them, they're at the point where their clothes, they can't stand touching their clothes, then if the affected nerve is in a distribution where I can catch it above the supersensitive area. So let's say, for example, you mentioned your hand. If I can catch a particular nerve higher up in the arm or somewhere, then I may choose to do that. But if based on the location of the body of where that nerve needs to be addressed, if it's in the area that's super sensitive, then I'm going to probably not go there first for risk of being slapped by the patient or something.
Just a reaction. We don't mean to do it.
Exactly. Yeah. When they say, does it hurt? I say, it won't hurt me a bit unless you slap me. But in those scenarios where I am concerned about, that's when I start thinking more TENS unit to catch the nerve up higher, or peripheral nerve stimulator, or trying to get things under better control with other modalities, whether it be medication or sympathetic block or physical. Of course, physical therapy is always in the background, so I haven't mentioned it in a bit here, but that's always in the background. So if we can get things better for them and take them from a 10 out of 10 to an 8 or a 7 out of 10, and everybody's perception of pain is different. So again, seeing where the patient is this tolerable for you? And allow you to do the things you want to do? If the answer is yes, then we'll hold the course. But if it's no, I need more help, then sometimes those patients are under better control where it's inappropriate to consider doing some of the things that maybe we could not do earlier. A lot of that tolerance for functionality comes with seeing where the patient is. If they're a person who just wants to be able to go to their mailbox and back and go to church on Sunday in the grocery store, then our bar is not quite as high for that 75-year-old grandma who just wants to see her grandkids versus someone who still wants to go play golf or go fishing or go hiking or what have you. So that has consideration as well.
Great. And that's awesome. With everything it's all personalized to the individual and what they're going through and what they need and seek and what they've tried in their own makeup, instead of having that standard treatment for a person of, you weigh this much, this is what you're going to get, or these are your symptoms, this is what you're going to get. So I like that. That's very nice to have that individualized plan for each person. Let's see, because we're almost down to time here for you. One thing I always like to ask is how you learned about the foundation and what made you decide you wanted to be a resource?
I can't remember who on your staff emailed us, but someone emailed called our clinic, and when I was asked if I would mind being involved, the answer was emphatically yes. It was just a question of when could we get together and the timing. So I'm glad we were able to get together. But anything that I can do to connect with other clinical colleagues that have a similar philosophy of establishing a good culture and relationship with patients to work towards a win-win scenario, not necessarily a win-loss scenario or you're absolutely healed versus not. Life is a journey and we all have our challenges, so we have to get through it together. And where humans are meant to lean on each other. None of us, as macho as we want to be, are going to make it through life on our own. The challenges, or our mission, in my opinion, is to do as good as we can for other people to get a lot of credits in the bank, so that when you do need help, you can not feel too bad about swallowing your pride and leaning on others, and not feel like you're a burden. And so that's how I approach it. I want the patients to be able to get to where they need to be and who they need to be for the rest of their family or friends. And sometimes that's challenging. Sometimes it changes. You mentioned having to grieve a loss or an activity. I would challenge one of my patients, or as we were speaking, I would say, okay, we have life's a book of chapters, and some of us are warriors enough that we never want to close a chapter, and so the chapter sometimes has to be closed for us. Now let's figure out what we're meant to do next. And so I've even sent patients to take interest inventory examinations, for example. So it's just an online personality profile questionnaire that asks you a bunch of questions. You answer it from the heart, and it takes your personality profile and compares it to other people who are doing worthwhile things, careers or community service, that are very happy doing those things with a similar personality. And a lot of the things on that list most likely people will have heard of, but there inevitably is one or two things on that list they say, never heard of that, let me look into it, or wow, I had. And so I would highly recommend that for anybody when a chapter closes, particularly if it's a chapter they didn't necessarily were ready to have closed. Whether you're going from high school to college, or college to workforce, or workforce to retirement, or what have you. I've had family members that made significant career changes just based on doing that questionnaire and then following it up and doing some research. So we're all here for a purpose. We're meant to do something. It's not always at the right time that we planned or the exact thing that we planned. But if you keep positive and keep an open mind, then something always comes about. Just like you starting this nonprofit. I'm sure you wouldn't have started this nonprofit if you hadn't been faced with some challenges in your life as well. So I appreciate you setting up CRPS Warriors.
Yes. Deb actually is the founder. She set it up for it. And that was really what it was. It was exactly that. She had been through so many experiences of doctors not knowing and surgeries not going well, that she had to do something. She wanted to make an impact and spread the awareness, because my personal opinion is this all starts with that lack of awareness. And really that's why I found her, and I never left, because it was the same feeling of just having to try and do something or make an impact. And if you can help one person and make their day a little bit better than it was, that's good for me. And trying to just get the word out a little bit more. And I have noticed over the past year, it seems more people are aware than they were of the diagnosis itself, not necessarily past that, but there's been a couple times I've went and not had to fully explain it.
Yeah.
So
well, hey, it's progress, right?
Progress, not perfection.
Getting back to ketamine, ketamine also has been in the news media much more this year because of the death of a famous actor, Matthew Perry. And so it's gotten a bit of a bad light, but so did propofol, which is one of the drugs that I use every day as well. So it's frustrating from my standpoint to have people that should be my colleagues doing the exact opposite of what I would expect them to do. So that's frustrating. But the very next day after that news first came out, we had 3 or 4 patients come to clinic and said, "Are y'all okay? I hope this doesn't affect you all being able to care for me because this is my life." One was a patient who has long COVID syndrome, and this is the only thing that has allowed her to spend some amount of quality time with her child, which is very important to her. So it's important to us because it's important to patients, and we'll continue to do the correct thing for our patients. And if we can help shed some light on the appropriate ways to use the medication, then that's another reason we do that. Just for some of your patients, often my question is what to expect. So ketamine is a drug that at higher doses causes general anesthesia. It's a drug that was developed in the 1960s. So anesthesiologists have used it for many years with a lot of experience in its use. If you've a person who likes to watch Animal Planet or National Geographic and you see the veterinarians guarding wild animals and has their eyes open and is breathing and is stable, but they're just not responding, that most likely was ketamine. So ketamine has a person kind of space out a little bit at the higher doses, which is one of the few general anesthetics that we have that does not drop a person's blood pressure, make a person stop breathing right away. So we use it in high risk patients where that's a challenge, either because the patient has a difficult airway for whatever reason, or we want to keep them as hemodynamically stable during the initial periods of going to sleep. It's used in the emergency department to treat fracture reductions and things like that as well. But over the course of those years, it was noted that the patients that did get ketamine for whatever reason often had lower pain scores after surgery and needed less opioids after surgery. So there started the early investigations on what's this medicine about. It's not an opioid. It does have some opioid receptor activity, but it's mostly receptor activity at other places as well. In addition to that, it was also found that patients who got any dose of ketamine around the time of surgery also had lower incidence of postoperative depression or anxiety as well. Again, that kind of started the initial looking to see what this was about. So all that being said, when a patient comes in for ketamine infusion therapy, then after we talk and set expectations, then once the infusion starts, the common descriptor that we frequently get is that a patient feels floaty. They'll feel floaty. The textbook medical definition or term is called dissociation or dissociative anesthesia, where you just get disconnected. Some people will literally feel like they're better able to come outside their body and evaluate their body or their life or what's going on, kind of like an adult would do to their child. The child doesn't really see the big picture, but the adult say, "I'm telling you, you got to stop doing that at school, or you need to study harder, etc." And during the infusion, some people may see some floats or one of the side effects of ketamine is it makes your eyes twitch a little bit. So sometimes people will see the walls a little bit. So oftentimes people just close their eyes and relax. If the patient has high risk of nausea, then we'll give them anti-nausea medicine as well. And the infusion lasts for usually between 40 and 60 minutes. During that time period, we closely monitor them if they were in the operating room, so they have blood pressure, heart rate, oxygen, if need be, and respiratory rate monitored throughout. And we watch them to make sure that they're safe and stable while they get the treatment effect. The 2 examples I give a patient, particularly the first time, is during the infusion, you're often like an astronaut doing a spacewalk. So you're in space, you come outside the space shuttle, but you're not floating off to infinity. You are connected to the space shuttle. You're in your spacesuit, your spacewalk suit. You have your communication, you have your oxygen, and you're doing your job. And then once you finish your assessment or repair of your job, then you go back into the body or the space of the space shuttle. And so that's often how the ketamine infusion may feel for some patients. The longer term effects that we're working towards is trying to increase the connectivity, for anxiety, depression between the logical part of the brain and the emotional part of the brain. Or for chronic pain, we're trying to increase the connectivity and pathways for the nerves to actually function as they should, and have the pain nerves be less active and have the non-painful generating nerves for light, touch, and etc. Respond as they're supposed to, which is not should not be painful. But from the emotional part of the brain connectivity, I like to give an example of an adult, whether it's a mom, dad, aunt, uncle, walking down the street with a toddler. Let's just say a 3-year-old, and they're holding the toddler's hand, not too tight, not too loose, but just right. And as they go down the street, imagine the toddler being the emotional part of the brain of this one large organism, and the adult being the logical part of the brain. And so the toddler sees something across the street that's bright and shiny, and the toddler emotionally just automatically wants to cross the street. And the adult will automatically grab a little bit tighter grip while they assess the situation, and they'll look over and decide that it's not wise to cross the street right now. And depending on the toddler may want a broke leg and kind of fall and have a temper tantrum, particularly since they're a 2 or 3-year-old, or they may just say okay and walk on. But in the challenging situations where there's a temper tantrum, then that's where the logical part of the brain or the adult hopefully has enough tools to help get through that emotional kind of, I'll use the term breakdown, but help get through that period. And they may or may not. There's a situation where you can imagine the adult just immediately chastising the child in a loud voice, and the child getting more upset. And the adult is not able to handle that situation. But with therapy, reading, journaling, talking through things, visiting with other warriors, you put more tools into your toolbox. And so in this scenario, when the child gets ready to throw their temper tantrum, the adult may look around and say, hey, there's a playground over there. Let's go to the playground. Then the emotional part of the toddler tends to kind of calm down and redirect. And so if you can imagine being able to be more aware within ourselves on those connectivity and realizing when things are causing stress before they cause you to have a panic attack, and you have the tools to address that, then that's what ketamine allows you to do in conjunction with a multimodal approach, whether it be other pain management modalities and or therapy.
Right. That makes complete sense. And that really does showcase to that mind-body connection that we have, that how much those two things can play off of each other. Like we had said, and you mentioned that they can be causing each other or increasing the dysfunction, and seeing how that all works together, and that can correct that. It's,
Absolutely.
And it can correct more than one at the same time. Excuse me.
Sure.
So that's huge. Let's see here. We're right about 5 o'clock. Is there anything else that you wanted to include that we haven't touched on so far?
The other thing that I'll just say is that one of my missions is to, on the anesthesia side, is to get to an opioid-free or near opioid-free total joint, because of the risk of opioid addiction on the backside of patients coming in for surgeries. People who have never had opioids, that's oftentimes the first time they get exposed, which really increases their risk of addiction. And people who do have a previous history, it's the one time where they get re-exposed or their exposure increases, which increases their risk of opioid use disorder exacerbation as well. So that translates into the world of chronic pain, and we really want to minimize and, where appropriate, eliminate opioid use. So all these modalities, including ketamine, are modalities that help us with that. So that's very important to us, especially in this day and time. And you talked about CRPS being more of a household word lately. Certainly ketamine this year has been more of a household word, but also the opioid epidemic and wanting to minimize opioids has been a big consideration for lots of people as well, where they'll either come in for ketamine with questions about that. I wanted to clarify that opioids do have withdrawal, they do cause constipation, other things. Ketamine is not an opioid, and whereas we do monitor people for coming in to make sure that they're not just wanting to have the psychosocial effect just for the fun of it, we don't see on a regular basis any type of withdrawal symptoms if patients do come in for a few infusions and then stop. That also in time is very important to us. The typical infusions for anxiety depression is oftentimes patients will need to have about 6 infusions over about a 6-week period to come out of the valley and get back up on plateau. That can be done twice a week over a 3-week period. It can be done once a week over a 6-week period. The ultimate endpoint is the same. So I generally counsel patients that if you're really having crisis in a bad place right now, then you may want to start twice a week initially, and then we'll start spacing it out, because ultimately the goal is to, of course, space it out. But patients often feel, let's just say if they're feeling super bad, 0 out of 10 in whatever you want to call it, anxiety, depression, PTSD, CRPS, what have you. Then after the first infusion, they may feel less negative or less pain, but oftentimes it starts to fade after one to 3 days. And so that's why those patients may want to choose to come in twice a week initially. And then with each infusion, that period of effectiveness tends to get expanded further and further. So ultimately, after 6 infusions, our goal is to have a patient coming in maybe once a month or so for a period of time, making sure that they've got the tools that they need, they've seen therapy, they have whatever it needs from the multimodal approach. And then ultimately, we would love to get them to the point where they need to come once a quarter or maybe twice a year. For the pain patients, if they strictly pain with no anxiety, depression, and we may not start that aggressively up front, we may try to do once every 2 weeks or once a month with the infusion to try to get the pain under better control, which there's very few times where a patient will come in and, let's just say, 8 out of 10 pain and not leave with 0 out of 10 pain. So that's not the question. The question is the length. And so patients, I don't want to say always, because I don't want to be absolute, but patients often will leave feeling very good. And then the question is, after that first infusion, do we get them to a week or 2 or 3 weeks? And then when do they come back? So it's more about the timing, and that's what we're spending a lot of energy on right now, is trying to be able to better tell patients ahead of time kind of what we expect on the timing once they get to the initial therapies.
I can imagine too, it might be a shell shock for them, as it's not an increasing treatment, it's decreasing as we progress, right?
Yes, yeah, true. That's very true. Yes, ma'am.
So that's a good thing. That's a good thing. I like that.
We like to work with the Houston chapter of NAMI, which is National Association of Mental Illness. We've gotten connected with you. I've also worked with Vet Solutions, which is a veterans program that's nationwide. So we're also doing our best to find other avenues and resources for nonprofit collaboration, grant funding, etc., so that we can cast this net wider.
That's good to know. Thank you so much for everything that you are doing and trying to get these leaps and strides going for patients and for caring and listening. I'm very grateful for you. Very much appreciated to know that there are physicians out there like you looking and researching and trying to make changes in a better world for people that have these illnesses.
Thank you for sharing, and thank you for spreading the word. It means a lot. It's very helpful for us, because we often do get into that grind of helping one patient at a time, but stepping back out to visit with you, hopefully in some way, shape, or form, will allow us, this podcast, to help many patients at one moment, one time.
Thank you for taking the time out to sit with me and share everything.
Yes, ma'am. Thank you.
We can't thank you enough, Dr. Jones, for taking the time to sit with us and give us all that information. All of Dr. Jones's contact information is in the description of this episode. If you'd like to support the podcast, please text CWF podcast to 53555. And happy November, everybody. This is a friendly reminder that November is CRPS Awareness Month. So our goal this month is to raise $10K to be able to continue to support our warriors in any way that we are able to.
whether that's through a scholarship, whether it's through funding the podcast and being able to put out information that can help and guide warriors to physicians and answers that they need for treatment, or running our support group that we offer for free to anyone suffering from any chronic pain condition. This month, we will be having extras and bonuses when it comes to our podcast. We have an extra group, 3 groups this month. If you don't follow us yet on social media, I suggest that you do so you can keep up to date with these bonus features that we'll be putting out this month for Awareness Month. All of our social links are in the description of this episode, as well as the link to our Awareness Month fundraiser and registration for our support groups. As always, it has been a pleasure, and I will see you back on the 15th for part 2 with Dr. Harris.